This week on the BackTable podcast.
I mean, what Chris said is so powerful, and it sums up so much of what we were talking about. The way that OB-GYN is designed is irrational, right? The fact that we have a system of training and practice that is designed around emphasizing obstetrics, which only ever accounts for 5 years of any given woman's life on average, right? The way that we've structured the whole thing is completely irrational and doesn't result in the outcomes that we want to see.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got with me, as usual, Dr. Amy Park. Amy, how are you?
Great. How are you?
Good. Work's good. Nothing new and exciting. Are you traveling like crazy to all your meetings that you're running, or is this?
No, that's in the fall.
Okay. I think you're nonstop. Well, we have another great episode. We have one returning guest. I think you were our first ever guest on the show, and a first timer. So we've got Dr. Louise Perkins King, who is an assistant professor of OBGYN at Harvard Medical School, MIG surgeon, and she brought with her Christopher Robertson and Neil Pike Scholar and professor of law at Boston University. So Louise, Christopher, welcome to the show.
Thank you.
It's great to be here.
We're glad to have you both, and we're going to talk about RVU disparities. And this is a topic that whenever I have questions about this stuff, Louise is always at the top of my Rolodex. We're excited to have you on the show, Christopher, to add your perspective as well. So thank you both for coming. We like to start all of our episodes with just our guests introducing themselves, talk about their careers, how they kind of got to where they are as it relates to the topic they're talking about. And Louise, why don't you go first? Because we know you, but we want to remind our audience who you are.
I'm Louise King. I'm a minimally invasive gynecologic surgeon in Boston. I've been in practice for 12 plus years since my MIGS fellowship. And about 4 or 5 years into fellowship, I wrote a piece for the Hastings Center Report, which is a big ethics journal, for lack of a better term. And in that piece, I described something that a lot of MIGS surgeons experience, which is this instance where we're doing surgery for the second time because somebody needs another surgery because of really bad endo that was discovered incidentally, or we're being asked to back up a surgeon who hasn't operated for a really long time. And in that piece, I talked about how I was really, really happy to provide that support to my colleagues, and I continue to be happy to do so. But I didn't understand why we had a system of women's health care that would allow that to be possible, because it doesn't really happen in that way in other surgical disciplines. And that led me down a huge rabbit hole. I ended up working on a piece that was published in the Green Journal with Katie Watson, another law colleague of mine, who helped me to crystallize this idea of double discrimination, where there's poor pay for gynecologic surgery and poor training for gynecologic surgery that leads to the situation. And then I was trying to understand, as a recovering lawyer, what I could potentially do about that problem. So I brought in some big guns from across the river, or we're still on the same side of the river as me. Sorry. Just Boston jokes. Sorry. But Professor Robertson, Chris, who is an amazing scholar and incredibly supportive, and did the huge effort to write this law review piece with me that really drills deeply into legal remedies that might exist to help us to create a solution to this problem. And we can delve deeper based on your questions about what RVUs are and how they happen and all of that when you feel it's right.
Great. Thanks. And Christopher.
Hi. I'm a law professor at BU, and actually not a fully recovered lawyer, still practice and consult and do jury research on a wide range of cases. Sued, products manufacturers and doctors and insurance companies. And my area of specialty is health law. But health law is a humongous field that covers everything from, of course, med mal to privacy to reimbursement to international human rights as examples. And so I was excited to meet Dr. King at a cocktail party, and we had lunch thereafter. And she starts telling me little pieces of the story, and I keep pestering her with each piece, like, well, why does that happen? And why does that happen? And why does that happen? And we worked all the way up. I realized the causal story has 12 steps in it. And after we had lunch, she sent me half a dozen articles that told different parts of the story. I thought we should take advantage of the ridiculous format that is legal scholarship. Law review articles are 25,000 words long, right? 6 times as long as a peer-reviewed article, even a big one. And so it took that much to tell the whole story, synthesize all those pieces, and then explore how the law permits insurers to pay 50% more for essentially the same procedure if it's on male anatomy versus female anatomy, and the consequences of doing so. So that's how we got together.
No, and it's a wonderful interaction that you guys are able to, take that little meeting at a party to something so important to not just OBGYNs, but our patients ultimately. And that's, I think, knowing Louise for a long time now, I know that her motivation is taking care of people and taking care of our patients and understanding why we're not doing as well as we could. And I won't speak for you, Louise, but that's, from what I know about you, that's the feeling I get when we talk about these things.
Yeah, I've always said I'd be happy to be paid less as long as I was paid equitably to other disciplines, so I had the same resources that I could bring to bear for my patients.
Yeah, so let's talk about some background. I mean, we've had guests on the show in the past. We've talked about RVUs, but let's do sort of like a brief review background, sort of as it relates to the disparities piece of it. So I think a lot of people think about work RVUs. When we say RVU, we're talking about the physician work component, which is sort of a foundation of how physician work is reimbursed, coming from how it was, CMS, the federal government, sort of gave doctors in a room an opportunity to decide what things were worth, right? I mean, that's sort of the sense of when it began in like the 80s, correct?
Basically, it began in the 80s, early 90s. Before that, we had customary fees. So what people typically were paid for things, and you could set those yourself, and they were different locality to locality. The government came together and asked the Harvard School of Public Health to do a study to try to create comparatively equal payment structures across different disciplines for similar work based on not only the amount of work that physical work that we do, but also mental work, the complexity of the care that we provide, the cost of actual physical tangible things for surgeons, that would be the actual equipment we use, as well as some consideration of the amount of malpractice insurance that comes to bear for the type of work we do. There are a few factors that lead into gynecologic surgery being paid less. First and foremost is that the original set points that were set in the early 90s by the Harvard School of Public Health gave very little to almost no consideration to gynecologic surgery as a discipline at all. So we have very fewer codes to work with, and that's persisted throughout time because it's hard to get new codes. And secondly, on this committee that now exists under the AMA and through CMS, where we have certain disciplines represented in the RVU committees, the RUC, in that committee, obstetrics and gynecology together has one vote, whereas other surgical disciplines each have their own vote. So our vote is deeply diluted by our understandable and laudable focus on obstetrical billing and care, which forms the predominant aspect of most OBGYN's work, but also is an area fraught with need for better funding in and of itself. So anytime that ACOG comes forward to try to advocate for better billing for gynecologic surgery, they only have the vote and wherewithal to advocate for that in conjunction with the other things they need to do in obstetrics. And the final piece of that puzzle that I'll put together for you is that under the law that established this whole system, there's a requirement of essentially neutrality, net neutrality in billing. So if ACOG advocates for further billing into gynecologic surgery, it's got to come from somewhere else. And the fear is it would come from obstetrics, or the fear of other groups is it would come from them.
So a few things, fewer codes, combo with OB. So the fact that we are sort of married to obstetrics as gynecologic surgeons, and the idea that the pot itself is finite. Fewer codes. That's one thing I don't know that I've talked about. Like, how many fewer codes are there for gynecology compared to like urology or colorectal surgery or other sort of like pelvic surgical fields?
It's improving in gyn-onc and in urogyn, but if you look at my discipline of benign gynecology and just look at endometriosis as a classic example, there's one code for a procedure that is incredibly complex and different and patient to patient and can involve a variety of different things. So for example, when I put a scope in and do an endosurgery, if I do lysis of adhesions, if I do deep ureterolysis, if I go perirectally, if I go crazy, right? It's the worst stage 4 case you can think of. I bill the same as if I put my camera in, looked around and burned one lesion. Exactly the same code. And so the fact that there's no ability to distinguish in that space is highly problematic. Or another example, the most common surgery that gynecologics do, a hysterectomy, is differentiated based on 250 grams. Well, there's much more to differentiate a hysterectomy from a hysterectomy, but we don't have the flexibility within our code system. It takes on average 10 years to get a new code going now. And so having started with fewer codes, we have fewer codes to work with.
And we both have been involved with ACOG in the past with the Health Economics and Coding Committee. One of the senses that I got as being a member of that committee was sort of fear, the idea that if we work to change a code or modify a code, the whole code set gets blown up and revalued. And so that stage 4 endo case may be valued more highly, but then the stage 1 endo case is going to be like pennies. And so the fear of like, well, we don't want to open this box because we're too worried about the negative downstream side effects or how it may impact fields outside of gynecology. And then you have the politics of how these codes get created at CPT and valued at the RUC, and you need your ACS colleagues and your other colleagues to either support it or not. There's so many factors that go into it. Well, let's just change the code. Like, okay, well, it's a massive bureaucratic system that, like our government in some ways, is difficult to make change. There's some good in that, but there's also big challenges when changes need to be made.
Yeah, I agree with you. And the committee that you're referring to is a committee of advisors that then advises the person appointed from ACOG to the RUC. And there's a variety of people on that committee at ACOG. But I think Chris's reaction to this is the best one. I mean, and you can react yourself, but whenever I would talk to him about all this fear and reluctance and then compare, for example, the orthopedists or other groups, cardiologists who advocate so strongly for their new codes and better billing, and Chris would say, huh?
There seems to be a gendered aspect to this. And the research that I sort of helped bring to the paper is that, well, first of all, it's worth mentioning that the RUC has 4 women presently out of 34 members. So it's 12% women, underrepresents physicians, underrepresents gynecologists, underrepresents women, of course. The piece we haven't talked about is how these codes are updated through surveys of physicians in the specialties. We haven't been able to get the raw data to look at the survey responses by gender, but we do know that gynecology and OBGYN has many more women in the practice than men. And there's this background literature that shows that in negotiations and other like high stakes situations, men are much more likely to overestimate themselves and to demand more. But the studies we cite in that paper, for example, shows that companies that have male CFOs, chief financial officers, are more likely to have to issue restatements of earnings because they previously made an exaggerated estimate of the earnings. And so you get this sort of reproduction of gender through this seemingly social science approach of these surveys, which, by the way, often have response rates of like less than 15% and sometimes like less than 20 respondents. Surveys that would never get published in a serious journal were nonetheless like moving billions of dollars in the economy. It's sort of a garbage in, garbage out kind of system.
No, it was one of those things. I mean, we all train for a long time to become doctors. Like, people train to do any job. It takes a long time to learn how to do it. Our schooling is specifically long. And then to get out and to sit on this committee and learn, wait, that's how this works. That's how all of this works. And having a role in an industry for which I knew very little about how the actual industry works. And it's hard to not feel like that's intentional. I mean, you go to business school, you learn about business. And you go to law school and you learn about the law. And that's cool. We learn about medicine. We don't learn about the business of medicine. And doctors 100 years ago decided this is a business. And we don't know how to run it. And we don't know how to work with it. And ultimately, we complain that we don't have a seat at the table, but yet we have no real knowledge about how the system works. And I think there's a big gap there. And I think that's maybe for a whole other podcast, and how most of us just don't really have any knowledge about how the healthcare industry works.
I was just really struck by what you said, Louise and Christopher, about this process of trying to bring social science techniques and evaluations of work through an esteemed institution like Harvard School of Public Health, and these surveys, and and then this sort of gendered response, because people will, in terms of valuing your own work, valuing your time and effort and mental stress and everything, it's like, oh, it's not that bad. And then somehow these other specialties are able to work the system to their advantage, while we're like governed by fear or whatever you're describing. I mean, I don't know. It's very strange to me. I do see that, though. And I'm, as a urogynecologist, I think I've benefited greatly from urologists having no fear, and they are a very powerful lobby and have greatly benefited. Slings are 12 RVUs. That's incredible. I mean, that's comparable to a hysterectomy. What you're saying about the social science experiment of like doing these surveys, which are trash. I didn't even realize that was the response rates, which is terrible. And you can't even coach people because that's illegal.
Oh,
people
but they do.
Yeah, I'm sure. But I filled out a couple of those for in the past. I mean, I've been in practice now for 15 years, and people just have no idea how the whole system works. I skimmed through your paper. I just need to plug that paper is coming out. It looks like in the Emory Law Journal. It's amazing. It builds on your Green Journal work, Louise, and it does put a law lens, but also sort of like that social science law journal lens. And I encourage everybody to read it. I don't know if it'll be available online, but
it already is.
Oh, it is?
I hope you can add a link below. We have it out as a preprint on SSRN.
Oh, perfect. Yeah, that would be great.
Just to fill in some further details, the response rate for most surveys is around 15%. For ACOG surveys, it's less than 2%. So we never fill out our surveys. And in terms of coaching, from what I understand, maybe it's coaching, I don't know what it is, but frequently people in other disciplines are counseled to fill out these to their advantage. I mean, there is definitely a movement among other surgeons to fill surveys out to their advantage. And in the 80s, that might have been the only way to get that data, the surveys. But now we have accurate EMR data to show us what at least the time involved in procedures is. And sometimes that would go to our advantage, sometimes not. But at the very least, again, what I want to see is equity in this system. And then not just for us, equity for pediatricians, equity for internists, equity for all of the disciplines that are underfunded in our system, because we really need to get care to where it needs to go and stop having these highly inflated surgical disciplines. But the only way to do that is for people with a vote at that table to push, which so far I don't think is going to be coming from ACOG, as Mark and I have seen, versus potentially other administrative or legislative options.
Well, I think ultimately you're asking people to take less money so you can make more, right? That's where with the net neutrality law, I mean, not net neutrality, but like it has to be net neutral for this. The pie is fixed in this idea that for women's health to be more equitably distributed, the payment to be similar, it has to come from somewhere. Well, who's going to volunteer to give a piece of their pie away? And I think that we're in a situation where we're sort of stuck. We feel very stuck anyway, where it feels like, well, no one's advocating for us because no one wants to give us anything because it has to come out of their own pocket, right?
I was going to say, it doesn't have to come out of ACOG's pocket.
No, other specialties.
And they have certain votes, but I guess my argument there would be that potentially there are ways to push this in legislative fashion to acknowledge that there's been a discriminatory effect, if not intent, from the outset of the set points that were established by the Harvard School of Public Health, and really drill down into the, in my opinion, unconstitutional inequities that exist in the system, the way that it affects women's healthcare. That wouldn't be beneficial to the pediatricians that I'd love to help too, but at the very least, to achieve equity in healthcare, surgical healthcare for women.
Well, unfortunately, kids aren't a protected class, but women sure are. So, I mean, they have a pretty clear constitutional claim.
Interesting. I didn't realize that. That's a legal basis?
That's what we're trying to get at, is that, yes, you're right. It's the way that the system is set up. We'd have to fight really hard at the table at the RUC and get other surgical disciplines to agree to give up some of their own funding, which is highly unlikely to happen. But arguing it from a different perspective of saying, hey, this is deeply unfair and even potentially unconstitutional. We need a legislative action that would go beyond the budget neutrality and fix this, at least to create a new set point so that we can achieve equitable care for our patients is the angle that we're trying to take.
Wasn't there a paper by one of the urologists who looked at the time and looked at RVUs? Because I remember seeing that on social media, and it was fairly accurate, but because they looked at the gender piece. I don't remember exactly. Christopher, do you remember what I'm talking about?
There's a key paper by Upal and colleagues that is able to compare the time reported in these surveys versus the time actually allocated under the National Institute for Surgical Quality. And so you get these objective data of how long it actually spends, compare it to the survey results. And they found that pretty much every specialty overestimates the amount of time they spend, according to this database. But OBGYN overestimates the least by 5 minutes per procedure on average, whereas Uro overestimates by 20 minutes on average, 4x as much. And so that's the sort of bias that goes into the survey results.
I mean, as a former OR medical director, my schedulers can tell you exactly who's good at estimating their OR time and who's not. Like, I've got a quick case, I'll be in and out in like 5 minutes, right? And we know that it's pretty inaccurate for most people in their own estimates. But time's an interesting measure, though, right? I mean, I think those of us who do, for example, hysterectomy for me is, a simple TLH. I should be in the OR in like under an hour, right? Someone who doesn't operate very much will take longer. Does it mean they're doing a harder surgery?
Oh, well, there's so many problems with time. I mean, living in DC and I'm in the company of lawyers. Gosh, some of my acquaintances said that they were told by their law firms, you're working too fast because they bill on time. So it's like, you need to have this, thread the needle so your 6 minutes will stretch or whatever. I mean, that sounds, no wonder you guys are academics, because that sounds terrible. Spending your whole commute punching in your time, but you don't want to, you have to have enough billable hours. That's rough.
I grew up in Kentucky in a horse farm, and this guy, Harold, I worked with on my first day, we loaded up hay on the trailer, sitting in the barn, he's sitting on the tractor, and my buddy and I are going, what are we doing? We're just sort of sitting here. He goes, you tell me, you ask him. So after about 5 minutes, I was like, hey, Harold, are we taking this hay anywhere? And he turns around and goes, boys, it's what you call getting paid by the hour. And that was my first lesson in time-based coding and time-based billing, because it didn't matter where the hay went. We were getting paid for the same work no matter what we did or no matter how little work we did. But those are the little life lessons you take with you, no matter how long you do something.
I don't think anyone's suggesting that time would then be like every minute you get an RVU kind of a thing. If we estimated the time correctly and as the average amount of time for any particular procedure, that would better incentivize people to do those procedures in a modicum of that amount of time, or, operate even more frequently to operate more efficiently, and thereby can sort of increase the revenues that you're bringing in, and those revenues can benefit your patients. So it appropriately incentivizing gynecologic surgery as a discipline in and of itself would help to ensure that we had more higher volume surgeons who are doing more throughput cases in the long run.
Time is just an input into the RUC's decision-making process, but we're showing the mechanism of how the decision get biased through this one input. But I was really struck when I learned about the bottom line, this very concept of anatomically matched procedures and other literature we rely on in the paper. I don't know, maybe Louise, you'd like to explain that concept, or maybe it's familiar to your listeners, but it was mind-blowing for me.
Mark, there was 2 papers in 2015 and one prior to that where a group compared anatomically matched procedures between gynecologic surgery and urology. And granted, a lot of them were minor procedures, but I think minors are still very important. And as they were comparing all these anatomically matched procedures, they found a very stark disparity in the amount of aggregate billing available to these surgeons. I think it was on the order of 1/3 less or more for gynecologic surgery as compared to urology. And much of the check, the ACOG check's objection to those papers, is that you're comparing two different types of billing codes. But again, my response to that is these are anatomically matched procedures. Why do you have different types of billing codes between female or male procedures? And then they were saying, well, but these are minor procedures that aren't done that much. Well, if anybody's spent any time in a urologist's office, you know that a good portion of their work is a lot of minor procedures. And having a wide mix of procedures is how you can create a discipline around a type of surgery. Another aspect of all of this is, for example, how in office procedures in gynecology, we have very little access to pain control as compared to office procedures in urology or dermatology. And that is also directly related to the fact that we don't have good billing for our minor procedures. So we can't set up structures around support staff to create good delivery of pain control within office settings. So as Chris said earlier, it's so complex. So that's why it was really fun to have the ability to write this all out in a law review paper where you have so much space to work with to describe all the different nuances around this topic. One of my mentees in the Masters of Bioethics program, who's applying to residency very soon, so keep your eye out for her, Nishita Ponglusa, and she's at Yale currently. When she came through to do her Masters of Bioethics at Harvard, she proposed to me that the fact that we can't adequately control pain in office procedures in gynecology is the result of historical misogyny, which manifests itself in these billing structures, which then creates a culture around pain, which creates a lack of empathy, which has been shown in medical student studies and stuff like that. So, the more I dig into these topics, the more I find that it really centers around creating equitable payment structures so that we can all achieve excellent care for all of our patients.
Can I just ask about the report that you're, and the objections that you're bringing up? Because it sounds like I had heard about the ACOG and AUA investigation rebuttal of the claims in the paper. And
what they found, they took all of those codes and compared them themselves, and they found that a difference exists. They acknowledge a difference exists, but that it's not statistically significant. I don't know what would be statistically significant when you compare codes that don't match up. I'm not sure what statistics has to do with that, first and foremost. But much more importantly, they will not release their analysis. So they say in their rebuttal that they're going to publish it. That was 3 years ago. They still have not published their analysis. In my request to them as a member of that committee to give me their analysis so I could look at it independently, they refused. And in our request through Freedom of Information Act request to try to get that data, we have not been able to secure it. Chris can speak to that in greater detail, but that's not transparent. I mean, if they're so sure that there's not a reasonable difference there, then just publish your finding.
I mean, just to top line that, peer-reviewed literature, multiple studies accumulating over the years, and this industry organization says, yeah, we did our own analysis, don't worry about it. I mean, it's just mind-blowing. I'm now a plaintiff suing CMS to try to get a copy of this report under FOIA because, somebody should have the report. And if, the crazy thing about CMS relying on AMA RUC is the AMA RUC is not itself subject to FOIA or anything else. You have to sign a confidentiality agreement to even go to their meetings. So it's really maddening. And to me, in law, we have this phrase adverse inference. Like if you hide evidence or destroy evidence, we assume that it was unfavorable to you. That's a fair inference the court will tell a jury. And that's what this is looking like. It just stinks.
And I'm obviously a big ACOG fan. I've devoted many, many, many years of volunteer work to them on various committees, and I'm their current chair of ethics. So I think ACOG gets a lot right. I honestly don't understand why they're getting this wrong. They are very blinders on, unable to see that this is truly wrong and that changes need to happen. I think, Mark, alluding to what you said earlier, they're fearful that rocking the boat will lead to things getting worse in general. And so I think that's why they're reluctant to move forward. But I frequently have people coming up to me at meetings. We were at SGS recently and saying, I'm so glad you're taking this on, but aren't you scared about your career? And I'm like, what does my career have to do with this? I'm just trying to get to the bottom of a question. And so the idea that I would be somehow under threat, that my career would be in jeopardy because I'm trying to ask these questions, also leads me to believe that some things are rotten in Denmark. But
that's hilarious. Like, what are they going to do to you? You know, the bar to get fired is so high.
Well, I mean, but why would me asking these questions lead to people being scared for me? You know, something's very, very wrong. And I don't know what it is, because the vast majority of people that I work with at ACOG and my work on the ethics committee are the most amazing people and are very clearly invested and desire to have wonderful improvements in the care that we deliver and all that, you know, everything good. So then to have all this happening in the ruck is so confusing to me.
I mean, I did hear about the ruck, and this is sheer hearsay rumor, but like, you know, and we talked about the structure of the ruck, but on a previous episode, but it sounds like many of the members are coming from surgical specialties, and there's allegations of collusion, the surgical bros colluding in the old days. I mean, I don't know if there's any truth to these allegations, but I mean, it's like birds of a feather flock together. I'm sure there was some horse trading or something in the old days. Like, it was set up in the 80s, right? Like, that is, and out of the 27 members, Mark, you were talking about this the other day. It's like, how many of the members are surgical specialties?
It was like 24 of the 27. I think there was peds, primary, internal medicine, and family medicine. And I think they've given them another couple of seats over the years. But like, it wasn't just surgery. It was orthopedic surgery, it was neurosurgery, it was urology, it was ENT. It was every surgical subspecialty had their own seat. And all of primary, like, you didn't get one for nephrology and cardiology and all the medicine specialties, right? But you did for surgery. And so it was that, are those numbers sound about right to you, Louise? It was something like,
that's accurate.
Yeah, 24-7 or 24-3, something like that.
And if you were objectively trying to design something that would come up with a fair and equitable billing and distribution of a limited resource of healthcare dollars to achieve the best outcome, that is not what you would set up, right? You wouldn't set up a closed room full of surgeons trying to make surgery more and more expensive. That makes no sense.
Well, it's just the idea that the federal government told the AMA, which I think many of us go, that's a medical organization. It's a physician's lobby. It's a physician's representative group. So you're giving a group legal power to decide what's a code and what's not, and say, hey guys, you guys decide what's a code, and then let us know how much you think we should pay you for it.
Administrative deference to experts is not necessarily a bad thing, like ensuring that they get the most accurate information by going to the source and saying, how hard is it to do this? How hard is it to do that? Because we don't want there to be no input, right? That's not what I'm advocating for. And I think, again, in terms of this question of what is ACARC scared of, I think they might be scared of that potential scenario, that we get no input. And I think that would be a bad thing. We do need to have input, and we are the experts on what this entails. But there are other experts that can, actuaries and others, who can look at raw data and try to help us determine what effort actually goes into any given discipline or surgery or whatnot.
Can I just clarify, this fixed pie, is it a fixed pie for the whole CMS dollars and, you know, everything, or is it a fixed pie for just OBGYN codes?
The first one, it's a fixed pie for the whole CMS reimbursement based on RUCs. So it can't go up by more than $20 million in a given year. So if you try to raise GYN reimbursements, they've got to find cuts elsewhere. going back to it, since I have the mic for a second, going back to a point earlier about who all has seats on the ruck. In the paper, we talk about, just as an example.
Yeah, ENT.
They have a seat on their ruck, but there's 4 times as many OBGYNs practicing. And so when you think about the representation of the GYN surgeons in particular compared to the ENTs, it's radical disenfranchisement.
Well, there's the work RVUs, and then there's other components to reimbursement, right? There's the facilities, and then isn't there inequity in those charges as well?
Yeah, diagnosis-related groups, DRGs, are how your facility gets paid for what you've done in an OR. We all hear from, if you have a seat at the table trying to get yourself more OR time as a gyne surgeon, you're told frequently that your cases don't pull in enough DRGs. And that has to do with the fact that a lot of our surgeries are on healthy individuals that go home the same day. But it also has to do with the fact that, as with everything in gynecologic surgery, the billing that is able to be negotiated is less than it is for other disciplines, even taking into account that our patients are typically healthy and typically go home the same day. And granted, that's not true for Urogyn and Gyn-Onc, which is where they've been able to make some good inroads in this space. But yeah, everybody gets paid less to care for women's gynecologic issues. And so then that leads to less OR time, less nursing staff.
Let me just flag that topic for an aspiring academic. The Upperman paper we were talking about earlier that looks at disparities in the RVUs, there's not a pivotal paper that shows them in the DRG space. The evidence is much more anecdotal there, prime area for future empirical research comparing the codes.
Yeah, I think that I know you and Jocelyn were working on this, Louise, about looking at turnover time as well. And Mark has some insight into this as a former OR director, but looking at inequities in the teams and, all these things that make a difference.
So yeah, Jocelyn Fitzgerald and I are trying to look at the DRGs, but it's very hard to get a reliable database. Whereas comparing RVUs is public information that you can pull off the CMS website and anybody can look at it and compare it for yourself. But the DRGs are to some degree proprietary as best I can understand. So it gets very difficult to parse into that data because institutions guard them to some degree. But in terms of OR turnover times, Kelly Wright's group did a wonderful paper recently from Cedars showing that even in the time span between when I end a case and when I start my next case as a female surgeon, my turnover times are going to be longer. And so there's aspects of that go into the pay disparity between female and male surgeons, if that's what you're referring to, because I can't get my OR to turn over at the same rate that a man can turn it over. And you probably have felt this as well, Amy. I think most women surgeons have, but if I make too much of a stink about it, it just gets worse, right? So all of that comes into play as well.
Actually, I looked at the data. We only had one male in our section, and it was all pretty comparable, 40 to 45 minutes. And then in my old job, it was just equally bad, an hour to an hour and a half. Mark, do you have any insight having worn that OR director hat?
No, I actually really appreciate what Kelly's doing and what you guys are doing. I mean, these are things that, look, as a male surgeon, I don't notice them, right? Because it doesn't affect me. My turnover times are fine. These are things that I'm so grateful for my colleagues that take the time and do the work to help people like me understand ways that, we're benefiting without realizing it, right? And so, there's a complaint about an area where it's unsafe and people don't feel safe coming to work. I'm going, no one bothers me. It's yeah, because you're a 6 foot tall guy. It's just different. And so you have to listen. You have to be able to give people time. And as I said, now, I'm 70% admin now in my time. And so much of my job is listening to people who do things that are very different than what I do. But this is a big piece of it. I mean, there's no question that my job in many of these conversations is to just shh and listen. And when people tell you things that are important to them, that you have to try your best to understand different perspectives, because I'm never going to truly know what it's like to be in a situation like that. And I know you guys talked about a lot of different pieces of it, but ultimately, the system was built for me. And so I have to acknowledge that, be willing to say, okay, let's try to build it for more people. I'm not saying you have to make it so it doesn't work for me, but let's try to make it work for more of us and make it more equitable. Like you've said again and again, Louise, the idea is not to make it necessarily harder for me. And I understand that may be part of it, and I'm okay with that. But I think asking others to do that, the more likely successful avenue would be, let's make it better for everyone so everybody can have a day like mine, right? That's the goal, because honestly, like, it's hard for me to know what it would be like not to be me. So I just have to listen.
So can I just ask about going back to where do we go from here? How do we work within the avenues to affect change? Because it bakes in all these inequities. You're not profitable. You don't have access to OR time. You don't get good teams. I mean, not here. In my situation, I have very good teams, but all these things kind of get baked in, and your productivity is less because you can't schedule in, 3 cases instead of, 2 cases instead of 3 cases or what have you. Like, what I've heard recently is ACOG is trying to break open the bundling for the billing, and that's our major focus, getting back to the obstetric focus of ACOG. But like, how do we get change? I mean, you had alluded to legislative solutions, like advocacy.
I think ACOG's very interested in creating better billing structures for obstetrics. And again, I support them in doing that because we need that change as well. But they're not going to be interested in really helping with gynecologic issues at the moment or anytime in the future, in my opinion. So legislation might be an option. And Chris has done some great lobbying on the Hill and will continue to do that. And anytime I can get the ear of any legislator, if you know of any legislator, mentioning to them that this is an issue that somebody really needs to take up.
To make sure I don't lose my job at a nonprofit institution, I wasn't technically lobbying.
Oh, sorry.
I was educating some people on Capitol Hill. I have the luxury of being outside your world. Let me just say something rude about it is you guys got to organize differently. I mean, it doesn't really, if I go to Capitol Hill and Louise goes to Capitol Hill and call my legislator, it's not the first question I heard every day when I would talk to different people is what's ACOG's position on this? What's ACOG's position on this? And until you guys have a voice of your own, somebody with a little bit of money behind them and a day job, I just don't think anything's going to change until you guys have organized as a profession. And that means, you're going to have to start sending some money to an organization that can actually stand up on this sort of issue. And I think second, that sort of movement has to engage with a new version of the women's movement. I think the women's movement have been so focused on abortion for the last period of time. As somebody from Kentucky, Mark, somebody from Missouri, abortion doesn't always resonate with people the same way that this issue can, because all women need gynecological care through the course of their lives. So I think there's some coalitions to be made. There's some framing, but you got to jump the shark. You got to get out of this mindset that, can we persuade anyone at ACOG? Because as Louise said, that ship sailed. You've tried that.
Well, Christopher, I think the challenge, though, is the calls coming from inside the house in this one, right? I think the problem is us, right? And I think we have organized in a way that we have conflicting interests. I mean, look at our training, right? And you guys wrote about this. 4 years to learn to be an obstetrician. I think obstetrics is quite hard enough, in fact, that I don't do it anymore because I don't feel comfortable dabbling in it. Primary care, my dad's an internist. He knows more than I'll ever know. And if my patients ever ask me about blood pressure, I'm like, go see a primary care doc. It's a lot. Oh, and by the way, you need to learn how to be a surgeon and do it in 4 years. And then when you come out, do 2 to 4 hysterectomies a year. And as good as you thought you were, stay good or get better. We've created an impossible situation, right? So we're setting people up to fail and we blame them for failing. I think we have to own it. We designed it. We're supporting this structure of training. The average general surgery residency is 5, 6 to 7 years long. And what percentage of them go on to fellowship?
Most.
85% of general surgeons go on to fellowship. So they're going like 6, 7, 8 years to be surgeons, and we give them 15 months in our field. And so what is our expectation for our trainees? Is it realistic? No, of course not. What is our expectation for the quality of the work we're doing? And all of the things we're doing, we're playing a different sport compared to the other specialties. And so I think we either decide this is different and matters, and we separate it. I think it actually adds value to both things. It's saying both of these things, obstetrics and gynecology, are both independently very important and both independently quite difficult. I felt that way strongly enough that I stopped doing OB and did a fellowship and And my wife said, wait, you did a fellowship, you spent 2 years to make less money? I'm like, hold on a second. Let me explain this. Kind of, but ultimately, like most people with the brain don't make those kinds of decisions, right? And so I think we want to incentivize an outcome that we want. And we want high quality, we want good people doing this thing, but the system does not incentivize the thing that matters to, I think, most patients, right? Which is having a high volume surgeon who has really good outcomes. But we're not made with, that's not the system we built. So we got to change the system. But because most of the vote getters are obstetricians, and this, we have to go to a different district, right? We have to go to a different group of people to get them to care or think differently. And that's why I wanted to have you guys on the show. And this is where this all came from was, I have a question. I call my friend Louise and say, hey, help me understand this. She says, let's have Christopher on the show and we'll talk about it. Because ultimately, whatever we're trying to do ain't working.
And I would just love to build on what Chris was saying. We can't rely on ACOG for this problem. Again, I love ACOG, but they are not our ally in this issue for whatever reason. I've never gotten to the bottom of it. AEGL is not necessarily going to be our partner in this topic because they've never organized around a PAC or around trying to influence legislation or policy change. That's never been something they've been interested in to date. Maybe they'll change. But SGS does have a PAC and is interested in creating change in this way. So I've been working to try to get in touch with people who are on the PAC at SGS who might be interested in this being a topic that they really explore greatly. But we do need, and obviously SGO and OGS and those groups are the ones that need to come together as a larger coalition to really push hard for change in this space.
So how are we going to do it? I mean, so we have a plan. How do we, it just feels monumental, right? We have these institutions that are just, it feels to me to be carved in stone. We have a few plucky lawyers that are, right? This is going to be, this should be like a made for TV movie someday if we can get it done. But we meaning you, but like, it just seems like this is, good luck. It just seems like an insanely tall order. I don't trust anyone more than you to do it, but yeah, how does it actually get done?
It is a tall order. I don't know the exact answer, I'll be honest, but I do think that if we had enough organizations behind making noise about this and really got out there with that type of noise, we could make some progress. I mean, a good example is some of the work that Shannon Cohn's done to increase funding for endometriosis research in the order of millions of dollars through legislation by creating a documentary and creating buzz around that. Obviously, we're not going to create a documentary, but creating buzz around this topic with the backing of major surgical organizations saying this is unsustainable, inequitable, and potentially unconstitutional. We need to deal with this will, I think, tip the balance towards change. It's not going to happen potentially even in our own careers, but I think that's where we'll have to put that kind of pressure because Chris is correct.
The whole back half of the paper asks the question of who can we sue?
Now that's what I'm talking about.
I think, I do think there's a path for doing politics, like adults in DC. And that's not just people showing up now and then to call their legislator. But failing that, I do think we can sue the federal government for setting the rates the way they do. It's complicated legalities around doing so because there's various immunities and judicial bars. But as far as we can tell with our research, you can actually sue the insurance companies. They are sitting ducks for lawsuits here because the judicial bar that protects the federal government doesn't apply to the insurance companies. I'm talking the Aetnas and the Blue Crosses and the Cignas and the Uniteds and et cetera. If I was an executive, I would be worried about this, partly just because it makes terrible press that we're underpaying for women's health care. But they actually have some liability under the Affordable Care Act, which creates a non-discrimination rule. I think if anyone listening here is, I can't solicit clients, I'm not a lawyer, but I can connect you to a licensed lawyer. If anybody's a GYN practice group that is interested in standing up to the insurers, I think there's a role for doing that. So let us know.
Yeah, no, it's an interesting approach, one that I think, like we talked about, trying to ask the same people to change their opinion for 60 years is likely going to give you the same answer every time. And so to be able to look at this from a different lens, a completely different lens than most of us physicians. Again, most of us have no idea how this stuff even works, let alone have an opinion about how to approach this. And then to go one step further to dig into it from a legal perspective, to me, is truly novel in a sense that, and in a way that I've not heard of it from anyone but from Louise and her now, our guest, Christopher. So this is what Louise and I ended up talking about when I called her. And I was like, we just have to have this be something that people hear about, because ultimately it just feels like something has to change. We're seeing it every single day. And I want to make this very clear, like to all of our listeners and anyone who's not in medicine who may be listening, this is ultimately always about patient care. We can say we want, oh, you're just trying to get paid more. The reality is when you pay more for a procedure, it gets done more. If the reimbursement for a procedure goes down, it gets done less. So it's not that money's the only thing. Sure as heck matters. And if you want to, and part of why I do what I do, and I'm as an administrator, and why I wanted to get into this part of healthcare, is because I believe you understand the system well enough to create a system that creates the outcomes that you want. And so if we want better healthcare for everybody, if we want it to make sense, you have to understand the system enough to change it, to make it work for you. And if you have patients at the forefront of your mind on why we're doing what we're doing, should be about patients, money can make an impact. We've talked about this on the show, 17 years, seminal paper to actual changing a clinical practice, right, in the medical literature. You want to make a difference? Change reimbursement. It'll happen overnight. And we see it all the time. So I think that's something that if you want to make a change for patient care, understand how the business works, that'll be the fastest way and the best way to get the patient outcomes and the patient care that we want.
I think the evidence really backs up that it ultimately is about patient outcomes. And we didn't talk enough about that earlier in the show, but read the paper. The evidence is striking, connecting to surgical volume and payments. As you said earlier, it's just irrational for someone to take 2 extra years of training to get paid less. But that's why we call it structural sex discrimination. That's the title of the paper. It makes it irrational to give patients the care they deserve.
I don't think anyone could say it better. Go ahead, Louise.
I mean, what Chris said is so powerful, and it sums up so much of what we were talking about. The way that OB-GYN is designed is irrational, right? The fact that we have a system of training and practice that is designed around emphasizing obstetrics, which only ever accounts for 5 years of any given life, any given woman's life on average, right? The way that we've structured the whole thing is completely irrational and doesn't result in the outcomes that we want to see.
We've got some pretty smart, talented, and thoughtful people working on this. So thank you guys so much for coming on the show. I think it's not every day you get to hear something that's as new and big as what you guys are working on. And so I'm super grateful, not just for coming on the show, but for all the work that you're doing and looking at this in a way that gives some hope to the challenges that I think most of us who do this for a living feel very helpless and hopeless at times. And so to have some folks putting this much time and energy and effort to really thinking about solving this problem, I mean, again, having you on the show is the least we could do to at least get the message out there and to allow people to think about this in a way that I think frustrates many of us. And our patients don't even understand the impact and how big it is because it's massive. So thank you both. We'll provide links to your paper in the show notes and anything else you want us to make available to our listeners. We definitely want to have that. And that's the one thing we can try to do here at BackTable is to try to at least spread the work that you're doing and the message that you guys are putting out there. So thank you again.
Thank you.
Good to be here. Thank you. Bye-bye.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Jimmy Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.